I'm Joanna Sinwell. I am one of the board members of NAMI Johnson County, and I welcome you today to our monthly Lunch and Learn. We've got a really exciting topic. First, we've got Sabrina DeDore here, and I'm going to introduce you. She's got a very impressive resume, and her talk today is going to be about first episode psychosis and a wonderful treatment protocol that is going on with in Cedar Rapids and Iowa City. Sabrina is a licensed independent social worker currently working as a therapist and the supervisor for the FERST program in Iowa City and Cedar Rapids. Sabrina has worked with Abbe Center for Community Mental Health for 4 years. Prior to therapy, Sabrina worked in medical social work. She attended the University of Iowa School of Social Work and graduated in 2016. She enjoys working with individuals experiencing psychosis and their families, as well as connecting with other agencies in the community like ours to provide education on this topic. She also supervises intern students at the Abbe Center who are working towards a master's in mental health field. So welcome, Sabrina. Welcome to everyone who's on. And I do want to remind you that you're muted, but you can put your questions in the Q&A or raise your hand, and we can also answer questions at the end. Thank you.
All right. Thank you, Joanna. Okay, so yes, as Joanna said, I'm Sabrina. I am the program director for our FERST teams in both Iowa City and Cedar Rapids. So I'm going to be talking about first episode psychosis, what that looks like, and then a little bit more about our programs. So to start off, what do we already know about psychosis? So what does it look like? What causes it? Anything that anyone knows, you can put in the Q&A box, or you can raise your hand and verbally share that.
You know, what I know about psychosis is that it can often happen when people are kind of between the ages of 18 to 40, and it disrupts people at a time in their life that it is very serious in terms of taking them off the track of schooling or work, family relationships. It's a very serious disease.
Yeah, exactly. So, yep, we're going to talk about all of those aspects. So thank you for that feedback. Okay, so what is psychosis? So we typically define psychosis as this disconnection from reality. So what that typically looks like is a series of symptoms that we're going to break down those symptoms a little bit more. But those tend to be things like hallucinations, delusions, disorganized thinking. Like Joanna said, it can significantly impact your functioning. So it not only affects like your mind and your perceptions, but it can affect your behaviors, your ability to complete daily tasks or activities of daily living. It causes distress and it impacts relationships significantly, oftentimes with loved ones who are close to the individual experiencing this and not knowing how to handle it. So causes and conditions. There can be a lot of things that cause psychosis. Psychosis can be associated with other mental health disorders. So it can be a feature of other illnesses, such as MDD. So major depressive disorder can have psychotic features. Bipolar disorder can have psychotic features. There's other diagnoses as well that have that. We typically see it with schizophrenia, schizoaffective, things like that. But psychosis is also like a cluster of symptoms on its own. So it can stand alone and can resolve and not be a part of another diagnosis. We also see psychosis that comes from substance use. So oftentimes substance-induced psychosis we see pretty often. It can come along with neurological conditions. So, like physical health can cause psychosis. And then extreme stress, that tends to be a triggering event for people to develop psychosis who have no other predispositions potentially. So, early intervention is the most important thing. What we've learned from studies is that the earlier we can detect this and intervene, the better the outcomes long term. So, 3% of all people will experience a psychotic episode in their lifetime. So, 3 in 100. Less than 1% of the population will develop schizophrenia, but early intervention can slow down and change the progression of the illness. So, if we intervene early, we can usually treat with lower doses of medications. And oftentimes we can see lessened symptoms or remission of symptoms that does not, that the person will not continue to have episodes potentially. So, what are those features of psychosis? So, the main ones that we see are things like hallucinations. Hallucinations are sensory input that do not exist. So, for example, that can be hearing voices, that can be seeing objects or people that aren't there, feeling sensations on your skin, like you're being touched. Any of the sensory pieces can be involved in hallucinations. The taste and smell hallucinations are the most rare, but we do see those sometimes. Voices, hearing voices is the most common. Delusions are beliefs that are firmly held, even if they can be proven factually incorrect. So, those can be very mild and believable, all the way to pretty bizarre and like not possible. So, delusions are held onto firmly despite someone saying, okay, well, here's these facts that show that that's not true. If someone is having a delusion, they are still going to believe that delusion is true and is factual. So when we talk about delusions, that can be things such as, my neighbor is out to get me. That's possible. That could be true. That's hard to disprove. All the way to I've been abducted by aliens and my organs have been swapped out. That's not possible, but they can still believe that to be completely true. Disorganized thinking and behavior. So that is the more outward appearing features of psychosis. So when we talk about disorganized thinking and behavior, that is thoughts not really making sense or aren't logically going together. So someone is trying to explain something and they're jumping around to different things that they can't like keep a train of thought. Disorganized behavior is behaviors that don't make sense for the situation. So that could be an example I use is wearing like beach clothes outside in the middle of a blizzard. Like doesn't make sense, not appropriate, but feels okay for them. It can also look like unpredictable behavior, irrational behavior, or socially inappropriate behavior. So the disorganized thinking and behavior is very outward. So these are usually what people pick up on, that there's something's off, something's strange, versus like delusions and hallucinations can be very internal and like not communicated necessarily. Impaired insight. So there is a part of psychosis that is called anosognosia, which basically means that someone doesn't believe that they are sick. So someone sick does not believe that they are sick. So the inability to recognize that these symptoms are happening or that they're not based in reality, or that they are not ill, not needing treatment, can impact the ability to get treatment. So that's very typical, especially at the very beginning. Negative symptoms. So these are kind of like those more depressive symptoms or things that are impacting like their daily functioning. So that is like decrease in their typical functioning, like lowered emotion, lower social engagement, so isolating more, having a flat affect. So that is kind of like that, like blank kind of facial expressions, like not really seeming happy or sad, just kind of like blank all the time. Reduced speech or movement. So kind of like catatonia can come from psychosis. So that is kind of like not moving at all or moving very slowly. Same for speech, like not speaking at all or just speaking very slowly. Lack of drive. So not being interested in the things they used to enjoy, not having any motivation to do those things. And then reduce personal care as well. So not keeping up with like hygiene or laundry or things like that. Those not being of much concern. All right. So, like I mentioned, with early intervention, we see the best outcomes. So that is why our program exists. So I'm going to talk a little bit about FIRST program. So FIRST program stands for First Episode Recovery Support Team. We are, like we mentioned in the beginning, we are located in Iowa City as well as Cedar Rapids. We are 2 of 5 programs in the state. Other programs have different names. Ours is just called FIRST, but I will bring up the other programs as well. So what we know is that long-term outcomes can be improved. We can reduce the severity of symptoms if they do come back. We can prevent them from coming back, and we can reduce the long-term damage that psychosis is doing on the brain. So our prescriber likes to explain psychotic episodes as doing physical damage to our gray matter in our brain. So every time we have an episode, and that is not treated or controlled properly, it is doing irreversible damage to our brain physically. So when we can treat it and use medication, coping skills, resiliency, that is going to reduce the impact of that physical damage that's happening. So how our program works is that we provide personalized care with very frequent touch points for not only the individual who's experiencing psychosis, but also their family and their support system. So when clients join our program, they can be as involved as they want to be. Some people are interested in all the services. They say, sign me up. I want to do it all. Some people are more hesitant or, not as interested in some of the services. That's always their choice. The only time that there would not be choice is if a client came to us on a committal, a mental health committal, in which case that requires that they see the med provider and take medications, but the entire rest of the program would still be optional. So most people still choose to do most parts of the program, but they can start or stop them at any time. I'll get into the parts of the program on another slide. So we combine medical aspects, psychological aspects, and social aspects in our program to work with each individual on whatever their goals are and however they would like to work with us to get to where they want to be. We promote skill building. So we want individuals to be able to reintegrate back into their lives in whatever capacity that looks like for them. So if that is, hey, I want to go back to school, or I want to continue working, or I want to be more social, whatever goals they have, we want to get them there. Getting back to work in school has actually been shown to improve recovery. So our program is based off of a curriculum called Navigate, and that was actually designed via a study. The study was called RAISE, and it was basically our program, but just in the study phase of it. And that is where we have all this data that shows all of these outcomes. So we know that this program is effective. And in that study, they found that in the past, the way that psychosis would be handled is, let's get you stable, let's get your symptoms controlled, and then we'll worry about work or school. But what they found in the program is that if we can continue to work on work or school goals immediately, like the sooner the better, that actually helps recovery, because it gives a client something consistent, something to work towards. If they're already employed or already in school, it kind of gives them, it gives them those parameters to work inside of, versus having no parameters, having no goals, trying to just manage symptoms first and then working on that. So that is very beneficial part of our program. Family involvement. So we emphasize family participation. We understand that although this is happening to the client, it is also affecting the family and the loved ones involved. So oftentimes families don't know what this is, which that's fair. Most people don't. So they don't know what to do. They don't know how to interact with their loved one. They don't know how to best help them. And we have a family education person on our team specifically for that reason. So we provide support to the loved ones as well as the client while they're going through this. And then long-term stability. So most people are in a program for about 2 years. And that is because with the study, they found that after about 2 years, the effectiveness of the interventions kind of like leveled off. So it was no longer helping the client improve. They've kind of gotten to a point where they're more stable and the interventions are kind of leveled off. That also encompasses that first episode time frame. So after 2 years, clients are no longer really considered first episode. They would kind of be more in recovery, or they would kind of be more in that severe mental illness space, in which case we would find them other services that were more fitting. Okay. So who is on our team? So as I mentioned, we have a psychiatrist. So our psychiatrist prescribes medications and monitors symptoms. So we do that because we want to get the client the best medication treatment based on their symptoms and their side effects. So we want to reduce side effects as much as possible. And I'll get into these roles a little bit more in depth in the next slides. We have an individual therapist. So we call it an individual resiliency trainer, which they help client manage symptoms by building coping skills, improving quality of life. This is based on module learning. So both the individual therapy and the family therapy pieces are module-based appointments, module-based learning. So what that means is there's a program curriculum, like I mentioned, that we work off of. So for individual therapy, that is, what is psychosis? That is, how do I cope with these symptoms? How do I build resilience? So there's all different modules that the therapist works with the client on. It's not traditional talk therapy in that, it's just back and forth. It's more, we're going to learn about this and I'm going to ask you for your feedback and we're going to practice these skills. Same for the family therapy. So like I said, that family education provider, they help the families with understanding psychosis and developing strategies to support the client. So again, that's module learning. That is, again, what is psychosis, information about medications, information about drugs and alcohol, all different modules. They tend to coincide with the individual therapy ones. We also encourage clients to participate in family therapy. They do not have to. We can just see the family without the client. However, we're often talking about the client and the client's experience, so we appreciate when the client can give their own feedback. And then we also have community and employment support. So our community support specialists and our employment and education specialists help clients with their social integration and their career and education goals. So that is typically done outside of the clinic, and we'll get into that as well. So here's our teams. This is our Iowa City team. So you have me, the team lead, and the family education provider. So I do both roles on this team. We have our prescriber, that is Chantel Rosmus. We have our individual therapist, that is Miriam. We have our community support person, which is Callan, and our supportive education and employment specialist, which is Kara. So on our Cedar Rapids team, we have some shared team members as well. So again, I'm the team lead interim for Cedar Rapids. Our prescriber is Ellen. Our individual therapist is Sarah. Our family therapist is Angela. And then again, our community support is Callan. And then supportive education and employment is Kara. So it's kind of nice that we have some shared team members. We work together very collaboratively, both on our individual teams, but also between teams. And we have some of that shared knowledge of interventions, best ways to support, ways that we've managed it with other clients, things like that. Okay, so getting into the roles a little bit more specifically. So our prescriber meets with our clients regularly, both to discuss their symptoms and their concerns. And we typically manage that via antipsychotic medications. So when we see clients, usually that's monthly for the prescriber. So they will check in with them every month. If they are making med changes, they may see them more than a month out. They may say, hey, I want to see you back in a week, or I want to see you back in 2 weeks so we can, keep a close eye on your symptoms or your side effects. There are some medications, some antipsychotic medications that require labs as well. So that could be part of that, just keeping an eye. We use a measurement-based care approach, and that compares clients' self-ratings and prescribers' ratings of symptoms in order to make a decision. So we do this via shared decision-making. So, the client will come in, see the prescriber. The prescriber has a specific list of symptoms that they go through with these clients every single time. And that is checking, are you experiencing this? Are you experiencing this? And that is both taking the client's word and saying, no, I'm not experiencing this, and the prescriber's observations. So they may say, are you having any unusual facial movements, things like that? And the client may say no, but the prescriber is seeing it. So it's taking both into account. That kind of goes back to that anosognosia piece as well. So clients may say, like, no, I'm not experiencing hallucinations or delusions, but then also be verbalizing a delusion to their provider. So that's kind of why we use both self-rating and prescriber rating. The other side of the prescriber rating is, since we work as a team, the prescriber are hearing things from the other teammates. So, if we're sitting with a client and they are experiencing delusions, hallucinations, things like that, then we would notify the prescriber of that. So they are aware of what's going on symptom-wise. So when they meet with the client, they can ask about that as well. So when it comes to medications, there are long-acting injectables available. Some of the antipsychotic medications offered have this option, not all. But if clients have concerns about remembering to take their medications, or if they are on a committal and required to take an injectable medication, then we can administer those at our clinic during the appointment. So we try to make it as convenient as possible for the client. So if they're already there seeing the prescriber, we'll have them get their injection the same day, or we'll align their other appointments with their injection date, so they don't have to be coming more than they want to necessarily. And then, as I kind of mentioned, prescribing is guided by our study. data. So the point of that is to lessen symptoms by using the lowest effective doses. So we want to go low and slow. With first episode psychosis, we're able to use usually about half the dose of later illness. So we do that because it prevents side effects as well. So the lower dosage we can use that's effective, the less chance there is for side effects. Every medication has side effects. Not everyone experiences them, but there is no medication without risk of side effect. So we want to take that into account. That's why we check in monthly. If a client is saying like, hey, I'm noticing I'm having this weird side effect, we consider, is that something that is bothersome to you or not? Is that something you would like to stop happening? If so, can we lower your dose? Can we change you to a different medication? Things like that. So we never want anyone to suffer from side effects that are unpleasant or that are really bothersome if they don't have to be. So as I kind of mentioned before, those are module-based education. So clients often meet weekly or bi-weekly with an individual therapist. And when it comes to family therapy, that's typically bi-weekly or monthly for family education. That is entirely up to client and family. So if client is saying, hey, I want to meet weekly, or hey, I just want to meet once a month, we're fine with any of that. We may recommend more frequent or less frequent. But again, this is entirely voluntary and their choice. Same for family. Some families are not involved at all in family therapy. Some of them are very involved. So, and then obviously getting multiple people together for family therapy can be hard to coordinate schedule-wise. So those just tend to be less frequent for that reason. But if family's available and wanting to do even weekly, we can do that. Those can also be virtual or in person. So we definitely have families who want to participate that aren't in the state or aren't in the same city. So we can do virtual and have multiple different family members on the call. The module-based education, like I said, that kind of coincides. They cover a lot of the same topics, but with a little bit different information. So the individual is more like, hey, here's this information on this topic. Let's practice this. Let's put this to use. And then the family education is kind of like, how can we support the individual? Some clients do have outside therapists as well. That is also their choice. So if someone is seeing a therapist and then they decide to join our program, sometimes they decide to keep that external therapist and see our therapist. Or sometimes they just keep their external therapist. Or sometimes they entirely switch to us. They have any of those options available to them. We will try to coordinate with outside therapists if they are seeing someone. However, we're specifically working with the client on psychosis, and oftentimes if they have an outside therapist, they're kind of working on other things with them. All right, so the modules I kind of talked about. So like, what is psychosis, medications, coping with symptoms, effective communication, substance use, and resiliency. Okay, and then our last two roles are community support and supportive education and employment. So our community support works with clients outside of the clinic setting to focus on their personal goals. The supportive education and employment specialist works with clients typically outside the clinic to work on professional and education goals. So this assists with things like maintaining employment and education or obtaining it. So if someone is currently not in school or not employed and they would like to be, we help them get there. If they are currently employed or currently in school, we help them maintain that. So whatever their goals are around that, we are there to help with it. Oftentimes that can look like working on a resume, applying for jobs, practicing interview skills, even attending with them to go to like a job fair, or if there are work or school meetings that they'd like the supportive education and employment specialist to attend, we're happy to attend with them. We can also help with accommodations at work or school. So if, our client is needing more breaks because of their symptoms or whatever accommodations seem appropriate, we're happy to A, attend those meetings with them, but B, write them those letters of support from our prescriber as well. And then our community support really helps build confidence and self-sufficiency outside of the clinic's setting. So it's a lot of real life practice and socialization. So that is, hey, I want to get out of the house and I want to socialize. The community support may go with them to like attend a group or an outing. Or, hey, I need help with food or I can't afford my rent this month. And the community support would help with like resource navigation or going with them to apply for assistance for different things. So really the community support and supportive education and employment are the other side of our program. So the less clinical side and the more like supportive outside of the clinic side. Okay, so who can be referred? So our program specifically works with clients usually aged 15 to 40. And those diagnoses are things like psychosis, brief psychotic disorder, unspecified psychosis, schizophrenia, schizoaffective, things like that. So like I mentioned, bipolar and MDD with psychotic features. So we can see psychotic features in those diagnoses, but they're typically excluded from a program like this just because we treat those differently. In those instances, we would be treating the bipolar or treating the major depressive versus treating the psychosis. The psychosis is coming along with those, and it's not its own separate piece. Substance-induced psychosis can be accepted case by case. So oftentimes we don't even know if it's substance-induced until later because you find that out typically via abstinence from substances. And abstinence is difficult. So, and not everyone wants to abstain from substances, and that's okay. So it's not an exclusion. Just because someone is experiencing psychosis because of substances doesn't mean we will not see them. We oftentimes will still work with them. When I mentioned the age range of 15 to 40, that is not concrete, but that's basically our guideline. We can go slightly outside of that range. So we've gone down to 13 and up to about 45. 15 to 40 is just the most typical time that psychosis shows up. And there has to be a cutoff somewhere. We can't take everyone. So that's kind of our parameters. When it comes to first episode, what that means is that someone has not been on antipsychotic medication for more than a year. And what that could look like for some people is, I've had an episode 6 months ago, and now I'm having an episode again. They're still considered first episode because they're still within that first year of treatment for psychosis. Or this may be their very, very first psychotic episode, and they've never been treated at all. So there's quite an array there, but generally within the first year of treatment is first episode. And let's see. As I mentioned, we obviously work with that first episode. The earlier, the better, because the outcomes are better. So that's why we kind of stop after. If someone has been on antipsychotic medications more than a year, then our effectiveness with our program is going to be much less. So that is why we have those parameters as well. So again, we have programs in Johnson County and Lynn County, and we also have programs in other parts of the state. I'll pull that up after the presentation. Last piece, how do I refer? So there is a referral form, or you can also just contact me and I can send the referral form if needed, but it's really just demographic information, who's the client, what's their phone number, what's going on, and then if needed, a release. So if you're working with another agency, we would have them sign a release so that we could communicate with you on the client if it's a shared client then. But anyone can refer. So it can be somebody that works in an agency, it can be a family member, it could be a friend, anyone can refer to our program. Those come to me. And then I will reach out to either the referral source or the client if they refer themselves. pretty quickly, usually within a couple days, and, talk about the program, see if they're interested in meeting about it. And then if the client is interested in learning more, I will meet with them usually within a week or so. And then I can usually get them onboarded within about a week after that. So we try to get them going as quickly as possible. Just because engagement in the beginning tends to be the highest, and we also want to give them these resources as quickly as possible, so there's less detriment to their daily lives, whether this is affecting their job or their school or their relationships. We want to reduce that impact, so we want to get them started quickly. All right, so the last thing I was going to show was that information about other programs in the state. So SAMHSA is who funds us. We are funded via government funds every year. And SAMHSA states that the government must allocate 10% of mental health funds to our programs. So our programs are called coordinated specialty care. And if you go on the SAMHSA site and you look up this early serious mental illness treatment locator, you can pick states, you can pick centers. But so for example, here's Iowa. Here's our first program in Iowa City. Here's our first in Cedar Rapids. And then there's also Siouxland and Restore in Des Moines. So those are the current programs in the state. There are other programs in other states. So sometimes I'll get referrals from the hospital, but the client may live on the border. So I'll try to connect them with the closest program. I think that's the majority of the information. So I would be happy to take questions. And if there's anything I missed, I'm happy to go over that as well.
Yeah, so I had a question back at near the beginning when you were talking about the features of psychosis.
Yeah.
They're pretty broad. Some of them, especially with delusions, I think that most people have situations where they believe something that's false despite strong evidence. So is there is it like a critical mass of features that you need for psychosis, or do you need more than one of these features, or how do you sort of judge that?
Yeah, good question. So typically if somebody is experiencing one of those symptoms, we would want more information, right? So if someone doesn't have a diagnosis of any kind, but someone suspects, hey, I think this person is experiencing psychosis, I think they could benefit from your program, we would have them see our psychiatrist for an assessment. At which point, the psychiatrist would kind of dig a little bit more to find if there are those other symptoms showing up as well, even if they weren't necessarily showing up for whoever referred them. So sometimes they can be pretty obvious and sometimes they cannot be at all. So the other thing is we can always kind of take a wait and see approach if really necessary. We don't love to do that because, again, earlier treatment is better. But if we're I'm seeing this client, they're kind of experiencing this, it sounds like, but I'm not for sure. We might have that person, that referral source, meet with them a couple more times, get a better idea of what's going on, if this is a situational thing or if this is a psychosis thing. And then they can always come back to us too. But if they already have a diagnosis of some sort, so if they were ever hospitalized or seeing another provider somewhere and they have an appropriate diagnosis, then we would accept that as well.
Tell me more about why bipolar psychosis wouldn't be appropriate.
Mm-hmm. So with bipolar and with major depressive, we treat those different than we treat psychosis. So there are some medications that overlap, but oftentimes not necessarily. So for example, bipolar, they often use lithium, things like that, which are not typical treatments in psychosis. They don't work the same way as antipsychotic medications. There are some antipsychotic medications that treat things like depression. So for example, like Caplyta, we use that for major depression. We use that for bipolar. But we use that for psychosis as well. So the main reason is because if we treat the bipolar effectively, then the psychosis would resolve. If we treat the major depressive effectively, the psychosis would resolve. For us in our program, when we're talking specifically about psychosis, we treat those differently. So even if, a bipolar or a major depressive did not resolve the psychosis, then we would know to treat it differently. Does that make sense?
Yeah, I think so. Like in the case of a manic episode with bipolar that turned into psychosis.
Right.
Long term, you wouldn't look at it like a schizoaffective or a
Correct.
yeah.
Correct. Yeah, we would just see it as a feature of like their mania, for example. So if we're treating the mania, we're treating the psychosis.
Although they would benefit probably from some of your programs, right?
Potentially, yeah.
I guess everybody would
Yeah.
benefit from, especially the community education and support. I've seen that help so many people with an array of serious mental illness. It's just such a wonderful program. Yeah. It's key, I think. It's really
Well, yeah, and that's like the piece that a lot of times is missing without a program like this. So somebody can be getting treated for psychosis with medications and therapy, but if they're not getting psychosis-specific education and they're not getting help with all the other aspects of their life that have been affected, it can still be extremely daunting and hard to get through some of these barriers.
Right.
Mm-hmm.
Do any of your clients know about our drop-in center or about our remote peer support?
I don't know, but I would love to tell them about it.
Well, I'm going to put you in touch with Laura.
Yeah, I can pull up my slide with the email again, just in case anyone wants that.
Yeah, I think there's some real great synergy there.
Yeah, definitely. Okay, there's my contact info too, Laura. I did also want to mention about funding. So we get often asked, how do clients pay for the service? If they have any insurance at all, it will cover most of the services. If they have Medicaid, it covers 100% of services. If they have no insurance, then we would help them apply for Medicaid. And then if they did not qualify for Medicaid for one reason or another, we have grant funding available to help clients access services. So we always want to make this available to clients without cost being a barrier.
Do you ever work with the shelter in Iowa City?
Yeah.
That's great. That's great. Like you said, your work with community agencies would be so important because they often would be in the front lines of identifying people.
Right.
How about schools?
Yep. So we've gotten a handful of referrals from like Iowa City Community School District, which is nice. So
that's wonderful. That's great.
Yeah.
It's such an important thing. I've seen it just change so many lives. Can you tell us a story, maybe without naming names, but could you share a story of one of your clients' successes?
Yeah. So, I mean, there's many of them, but for example, like one of the referrals we got from the school district was a 13-year-old in detention, and they had seen like this significant change in behavior over a short period of time, and they suspected it could have been psychosis. So we went to the detention center, met with him, determined it was psychosis that was going on. We're able to get him started on, an injectable medication, specifically because he was in a detention center. It was the easiest option. And his symptoms just improved significantly within a couple months, and he was able to go back to school. He got out of detention, went to school online, then was able to go back to school in person, and we were able to write a letter of support for that. And the school has been in contact with us about like a significant improvement. So that's been really nice to see that.
Great. What a great story. Thank you.
Yeah.
Well, thanks, everyone. Are there any other questions that we missed? Or, okay, I think not. That was it. Thank you so much, Sabrina. Really appreciate your time today.